Hello, my name's Todd. I'm an ACP from Queensland Ambulance Service. I'm going to be talking about the management of acute burns patients today. The effective pre-hospital care of acute burns patients is essential in the improvement in patient outcomes. A most recent review declared a mortality rate of only 4% of patients treated in a specialised burn facility. Our role as paramedics is twofold. Firstly, the interventions to keep the patient alive while transporting to a burns facility where they will have a 96% chance of survival. And secondly, implementing management that can have very large implications in the following hours and days. Thermal injury, also known as burns, results in a spectrum of local and systemic homeostatic derangements that contribute to burn shock. These include disruption of normal cell membrane function, hormonal alterations, change in tissue acid-base balance, hemodynamic changes, and hematological derangement. An integral part of the management of a burns patient is the assessment. The classification of burn severity has undergone change over the past couple of decades. Traditionally, the degrees system has been changed to the burn depth according to observed clinical outcomes and the requirement for surgical intervention. These are superficial partial thickness burns, deep partial thickness burns, and full thickness burns. The next step of the assessment is the surface area size of the burn, which is quantified as a percentage. There are many burn estimations methodologies available, but the two most common are the rule of nines and the palm of hand equals 1%. Rule of 9 method divides the body into segments in multiples of 9. This is adjusted in paediatrics due to the larger heads and smaller legs. The palm of the hand rule is a quick and simple estimation using the size of the patient's palm as a template. Every palm is worth 1%. The assessment of the surface area percentage and the classification of depth are very important in both the decision making with immediate management and the notification to the receiving hospital as to the severity of the patient's condition. The guiding principles of pre-hospital care for a burns patient are stopping the burning process, establishing and maintaining an airway, initiating fluid resuscitation, relieving pain, protecting the burn wound, and transporting the patient to an appropriate facility. But as we all like to work systematically, we'll begin this video as such. Once you have assessed for continued danger from the burning situation and ascertained for the patient's response, we'll start with the airway. As you can see here, the patient has already been RSI'd. Very diligent attention to airway is required because rapid swelling can occur. Intubation should be immediate in cases where stridor is present, increased swelling of the head and neck, unprotected airway due to ALOC, or the uncooperative, combative, or disorientated patient, where there is, and also where there is soot present in the airway. If hesitant to RSI, a stable burns patient, just remember one thing, that the largest increase in laryngeal edema occurs between the 2nd and 8th hour post-injury. Moving on to breathing. In the conscious and alert patient with a good tidal volume, 100% oxygen should be applied. In the RSI patient, just remember your lung protective strategies. That's a tidal volume of between 4 and 6 mils per kilo and a 5 centimetres of PEEP. Moving on to circulation. Initiate a large bore cannula in the non-burned skin. IV fluids are to be initiated, however, just remember, they are to be withheld or very conservatively used in patients with evidence of facial and airway swelling and upper chest burns prior to intubation, as this can lead to an increase in interstitial edema and airway compromise. There is also an increased risk of APO, acute pulmonary edema, and ARDS, acute respiratory distress syndrome. Following primary survey and assessment, the following management must be considered. Stop the burning process. We're going to remove the clothing from the patient. We're going to remove any jewellery because they can also retain heat, but more importantly, when there's that interstitial edema increase, you can have a tourniquet effect on the limbs, causing ischemia to the area. IV analgesia should be a priority. Burns are very painful and relatively large doses are required. Morphine and fentanyl are most widely used. Where this is not sufficient, however, ketamine can be used and is very effective due to its dissociation anesthetic quality. Thirdly, protect the burn wound. This is always dependent on the severity of the burns and the patient's time criticality. In minor to moderate burn cases where the patient is hemodynamically stable, the first step is called controlled cooling. And this begins with the running of cool, clean water over the burn for 20 minutes. This can be in a shower, under a tap. Preferably, this has been commenced prior to arrival. Most state ambulance services, EMDs, will initiate this as part of their burn management. This early cooling can reduce the depth of the burns and the pain, but we must be careful to not induce hypothermia. The soothing effect of cooling on burns is most likely due to local vasoconstriction. Cooling also benefits by stabilising mast cells and reducing histamine release, Keenan formation, and thromboxane B2 production. Following the cooling, there are two well-known methods for protection of the burns. Firstly, cling wrap, which is clean, thin, transparent, and non-adhesive. While applying the cling wrap, remember not to put it completely around the circumference. We want to make it easy to remove, but at the same time we're sealing the burns. Once you feel like you have a nice seal, the irrigation of the wound with normal saline. Once the cling wrap is in place, the continual irrigation with normal saline is the preferred method of cooling. This can easily be done by removing the normal saline from the packet, snipping off the end, and just slowly irrigating over the area. The second option for protection of burns is Burn Aid. Burn Aid is a sterile, cool dressing. The Burn Aid company suggests that it only be applied to small burns and scalds. On consultation and consideration, the QAS have created a guideline which allows for its use in patients with less than 20% burns in adults and less than 10% burns in paediatrics, with the understanding that the paramedic must continually assess for trending of hypothermia. The common anecdotal evidence from many paramedics is that although the guideline gives flexibility, many would not consider Burn Aid in burns over 10%. Instead, the preferred method of cling wrap with constant irrigation with normal saline is the preferred option. An interesting finding on the Burn Aid website revealed that it was not to be stored in temperatures exceeding 30 degrees. However, here in Queensland, I can guarantee that every packet has been exposed to this on a daily basis. Furthermore, due to the comparatively small amount of burns cases, it is not uncommon for a packet to sit in the truck for longer than a year. This may be something we need to investigate and change. I will now demonstrate the use of Burn Aid. Remove from the packet. Making sure that my surface area is not greater than 20% in this adult patient. I will now place it over the majority of the burns, increasing the surface area. Once the Burn Aid is applied, it is okay to use cling wrap over the top of the Burn Aid to keep it sealed. The importance is on maintaining the patient's normothermia. The surface area underneath the Burn Aid undergoes very quick cooling, and it's important that we completely monitor. Don't be afraid to remove the Burn Aid if hypothermia becomes a complication. I'm now on my way to hospital. I'll just run through quickly the management that I've performed. So the patient's airway was immediately protected through RSI. The patient was given ketamine, rocuronium, and fentanyl. The patient was RSI intubated with a size 7 tube. Airway is now protected. The patient has been put on lung protective strategy. We're breathing for the patient IPVV approximately 14 with a PEEP attached. The patient, once the airway was protected, the patient was initiated on fluid resus. We're now on our second bag of fluid. The patient has a large bore cannula in the non-burnt side. Unfortunately, this left arm has burns on it. we're prepared for IO down in the leg if this cannula was to fail on us. Protecting the burns, I have now placed, because of the size of the burns down the left arm and chest, the percentage was too high for the use of burn aid, so the patient's been cling wrapped, and on the way to hospital, while pre-notifying the hospital, I've got my partner dousing the body with normal saline as a constant. En route to the hospital, we're maintaining the vital signs, continued cooling where hypothermia is not a complication, constantly monitoring for temperature and constantly updating our sedation, continual respiratory observations, very aware of the possible interstitial edema, acute pulmonary edema and ARDS complications. In conclusion, burns are complicated patients requiring many priority interventions in the pre-hospital field. It is imperative that we understand the guiding principles to best improve patient outcomes in the future. Thank you for listening.